many years. We know how bacteria can transmit from one source to another, unlike Semmelweis, who did not know this at the time, but could see that there was a link. There needs to be a microorganism in play anytime that you see an infection occur. It has to find a reservoir or a home, and then from that home, there needs to be a mode of transmission. In Ignac's case, the hands were that mode of transmission that brought that microorganism from one place to another portal of entry in a susceptible host. In the OB area, I like to look at this as our chain of infection. We can see that bacteria can pass very readily from mom to baby, also from baby to healthcare worker and vice versa, and from the environment to mother and healthcare worker and back to the environment. So this interplay of four plays a big role in the transmission after birth and during birth. So we're going to talk a little bit today about each of the key elements, the mother, the baby, the environment, and the modes of transmission. So we will discuss the mother first. Patients can be a source, a reservoir for bacteria. We have known this for many years. We're colonized with all sorts of bacteria, both good and bad. When we look at one of the predominant pathogens that causes infections, methicillin-resistant Staph aureus is a bacteria that can be very aggressive. It causes skin and boils. It is resistant to methicillin or oxacillin, so those are the antibiotics that are used to treat it. We have seen some predominance with mothers being colonized with MRSA, both in the community and in the hospital. We've seen outbreaks due to crowding, compromised skin, contaminated fomites, close contact, and lack of cleanliness. The national carriage rate is 0.8%. So what that means is MRSA likes to live in those warm, dark environments, and the nose is the perfect environment for MRSA to live and replicate. And so when they have swabbed people's nasal passages, they have found a carriage rate of 0.8% in the population. But Staph aureus also likes to colonize in different body sites. So we will predominantly find it in the nose, sometimes on the forearms, the hands, the perineum, the skin, chest, and the axilla. Predominantly in babies, we'll find it in those diaper folds, in the perineum, in the armpits, and in the nose. MRSA nasal colonization prevalence is equal to vaginal rectal colonization in pregnant moms. So there's been some studies that have looked at the predominance of where MRSA likes to live on these moms and found that it's not only in the nasal passages, but it can be in the vaginal rectal area. Why this is important is because this could be an area where the baby would acquire it after birth or during delivery. And there's varied clinical presentations of MRSA. In pregnant mothers, they have found MRSA to cause skin, soft tissue infections on the buttocks, the extremities, the groin, abdomen. It can also cause mastitis, breast abscess, cellulitis, and wound infection. So for moms that have given birth and are breastfeeding, it can be a source of C-section infections as well as mastitis. So it is a tricky pathogen that is causing a lot of issues in our hospitals and with our mothers. A May 2012 Journal of Pediatrics prospective cohort, MRSA colonization occurred in up to 10 to 17% of mothers, so almost 1 in 5. Interestingly enough, they found infants born to mothers with staphylococcal colonization were more likely to be colonized, and early postnatal acquisition appeared to be the primary mechanism. So it is highly likely that we will see infants born to mothers with MRSA that can be colonized with this as well. Another April 2012 study in pediatric infectious disease, women at late pregnancy were screened for nasal and vaginal Staph aureus colonization, and newborns were screened for nasal, auricle, umbilical, and rectal colonization at birth and before discharge. Carrier mothers and newborns were rescreened at 1 month. What they found were, of the 208 women screened, 34% were colonized with Staph aureus. Overall, by 72 to 100 hours after birth, the cumulative incidence of Staph aureus acquisition was 42.6 out of 100 newborns of carrier mothers versus 7.4 of newborns of non-carrier mothers. So this is quite a shocking statistic, and I think that it shows how easily it is for bacteria to pass from mothers to baby, not only the good kind and the kind that we want to colonize our babies, but the potentially pathogenic kind as well. Following up on this study and under further research, we found that newborns of carrier mothers are at risk to acquire staph colonization. So how do we break the chain from mother to baby? This is a challenging task because the mother's pathogens and bacteria will rapidly colonize the baby. What we will do for mothers sometimes during admission, we will do active surveillance. So hospitals will typically can screen mothers upon admission. Not all hospitals do this, but some will. And they will preventively look for it in the MRSA nasal pathway, particularly in the ICUs, where the patients are vulnerable, and in pre-op patients. Many patients that go in for orthopedics or some type of implant will be screened for MRSA because of the likelihood of MRSA to colonize an implant. Hospitals are also reducing colonization of MRSA through bathing with chlorhexidine gluconate, which is a special type of bath that can strip the skin of this dangerous bacteria. Moms with MRSA will also be put into contact. So this means that a sign will go up on the mother's door, and the hospital staff will begin to use gown and gloves when they come in and out of the room. We often will get questions, how do we handle contact isolation with moms and babies? How do the hospital staff perform this while at the same time allowing baby to room in? And typically what we will do is we will isolate mom and baby with them rooming in. And so the healthcare workers will have to gown and glove when they come into the room. And excellent hand hygiene is needed. There may not be a total need for a cause for alarm for MRSA, though, because the Journal of Pediatrics May 2012 edition found that the best action may be no action at all. So as many as 20% of babies may acquire MRSA from positive mom, but have no real consequences. So the issue of decolonization of a positive mom is undecided. It is best that we put the mother in isolation to protect the spread of MRSA to other patients in the hospital. But what we suspect is that particularly breastfeeding may have a preventative effect on this acquisition of MRSA, and may also provide some antibodies against MRSA really causing an infection or doing any real damage. Some other interventions that we will do and that are best practice in the hospital is to wash all bedding, towels, and clothes at the beginning of the decolonization regimen. So we may see that mothers prior to C-sections will be bathed with a chlorhexidine bath. Their skin will be prepped prior to surgery to strip the skin of any dangerous pathogens. And we may apply mupirocin, which is a nasal ointment, into the nasal pathways to kill any MRSA that are there. But the best habits for preventing the spread of dangerous pathogens in the hospital setting, not only of MRSA, but other pathogens like influenza, GI illness, Clostridium difficile, really comes back to clean hands, clean patient, and clean environment. These will always be the mainstay of infection prevention. So upon birth, we'll talk a little bit about the baby now. Upon birth, the baby begins to rapidly colonize with organisms. Many of these are protective, particularly during vaginal birth. We know that the baby will rapidly colonize with the mother's normal flora. This is preventative and very protective. And if breastfed, a baby will acquire much of his or her initial immunity from the colostrum and mom's skin flora when the mom performs skin-to-skin holding after birth. So in a hospital setting where there are potentially dangerous pathogens, this is an immediate immunity booster for that close contact with mom, the colostrum, and that skin-to-skin holding after birth. One study demonstrated some major differences in neonatal gut colonization by the type of feeding. We can see that formula-fed babies had a number of potentially pathogenic organisms. The E. coli, Clostridium difficile, Bacteroides, Prevotella, and Lactobacillus. These are pathogens that we in infection preventionists within the hospital setting track. They can and frequently do cause many hospital-acquired infections, so they are on our radar. Many of these are gram-negative rods and are not the ideal organism that you want to be colonizing your baby right out the gate, as they can cause many issues within the gut, hospital-acquired bloodstream infections, ventilator-associated pneumonias, UTIs, skin infection. So the other major difference with the breastfed babies is we'll see more colonization of those good probiotics, those healthy, protective bacteria. So if you think of bacteria in two buckets, some are colonizing, they don't harm. Others are harmful and can be pathogenic. So we see more instances of breastfed babies having those protective bacteria, particularly in the gut where so much of our immunity is formed. Infants who spend time in the neonatal intensive care unit for long periods of time are at increased risk of hospital-acquired infections. If you think back to the first slide where we showed that upwards of 10.7% of our babies may spend some time in the NICU, this is an area where babies are put in close contact with each other. And when any patients or babies are put in close contact with each other, this means that there is more opportunity for bacteria to spread. Often when you walk into a NICU, you may see that they have special isolation rooms in the corner and the back, segregated, and those that have been known to be colonized with some type of pathogen, particularly MRSA, something we see a lot in this setting. These babies are particularly susceptible due to abnormalities of their immune system and outside factors like devices and surgical procedures. In the NICU, infection preventionists oftentimes will monitor these babies for bloodstream infections, urinary tract infections, ventilator-associated pneumonias, surgical site infections. So this is a population that is at risk for hospital-acquired infections, and we monitor them closely in the hospital. NICU hospital-acquired infections are associated with increased morbidity and mortality, prolonged hospitalization, and increased hospital costs. So as you can imagine, for mothers and fathers that these families that have these babies, they're excited for this birth. Their child is born prematurely or preterm, has to spend some time in the NICU. This can be a very traumatic event. Every day the baby is in there, increase the hospital cost. They're eager to bring their child home, but these infections can cause a lot of serious adverse effects and be very traumatic for a new family. So when we look at the NICU baby in particular, adherence to the 5 moments of hand hygiene and standard precautions, again, is the most important thing. So germs are 80% more likely to travel on the hands of healthcare workers and family members, as well as patients themselves. So hand hygiene during the 5 moments is the most important preventative measure that families, moms, and hospitals can do to prevent the spread of dangerous bacteria. And we will get into the 5 moments in a few slides. So if MRSA transmission is suspected in the NICU, follow your institution's policies and procedures. It is not uncommon for us to find a couple cases of MRSA in a NICU and then determine that we need to swab all of the babies within that setting. This was particularly likely in the past when NICUs were built as one large room and the babies and the families and healthcare workers all congregated in that space. Nowadays, with the new construction, many of the NICUs are going to single patient rooms, and that does do a lot to prevent the spread of dangerous bacteria from patient to patient. However, if there are breaches in hand hygiene, germs can still readily spread from room to room. So if we look at breaking the chain for the baby and some of the items that we can do to prevent the spread of dangerous pathogens to our babies, hand hygiene becomes very important before holding the baby, before nursing the baby. Exclusive breastfeeding also exposes the baby to all the immunological properties and benefits. And rooming in is a big pro for us in infection prevention. Rooming in means that the mom and the baby spend more time skin to skin in close proximity, where that baby will get that immunological boost from the skin to skin in the colostrum as well as the breastfeeding. Anytime that a baby goes to a NICU or goes into the nursery is an opportunity for germs to pass in these settings. So the more that a baby can room in, the better. It's preventative. Now I say that, but there are times that moms do need a little bit of sleep, and that nursery is a benefit. I know that I took advantage of that after I had my sons. So again, I say that knowing that you just need to do your best to keep our hands clean and keep our babies with us when we can. Many studies have shown the protective effects of breastfeeding, not only for hospital-acquired infections. We can see here where my browser is that when we compare babies that have been breastfed versus never breastfed and looked at the odds ratio of a GI infection, we can see that the breastfed babies have much better outcomes and less spread of those GI infections. So they have less risk of acquiring a GI infection than a baby that was never breastfed. Not only is breastfeeding preventative against hospital-acquired infections, GI infections, but it's been shown to be preventative with those long-term illnesses like breast cancer and other chronic diseases. This comes into play in the adult hospital setting where many of these babies, when they grow up, may come back in as adult patients, and breastfeeding can have a preventative effect on them even during later hospital stays in life. This is one of my favorite pictures of all time. This is a hospital room where VRE culture positive sites were found. So an infection preventionist likely went into a hospital room after a patient was discharged and did some environmental culturing of some of the high-touch surfaces. You can see here that these monitor screens, these drawers where the healthcare workers will frequently open, bedside table, chart, the sink, faucets, and other equipment were colonized with vancomycin-resistant enterococcus. And what that is a gram-negative rod, enterococcus, that's usually can be found in our intestines as well as in the environment, but is resistant to many of the antibiotics that treat it. And they found VRE culture positive sites in many of these high-touch surfaces. So we cannot say enough that our hospital environments can be, particularly if there are lapses in cleaning or frequent discharges and admissions like there are in the OB setting. In looking at the environment, healthcare-associated pathogens survive very well on dry surfaces. MRSA can live up to 120 days. Clostridium difficile can live up to 6 months on a hospital surface if not cleaned appropriately. Many patient areas, again, if there are stresses with frequent admissions and discharges or staffing issues, we can see that some of the rooms may not be cleaned according to our policy. Improved thoroughness of disinfection cleaning does decrease environmental contamination. So cleaning appropriately will kill all the pathogens. These chemicals are very effective. The Centers for Disease Control encourage all hospitals to implement and develop programs to optimize the thoroughness of high-touch surface cleaning. And hospital policies should include the use of an EPA-registered, hospital-approved disinfectant in many patient areas in conjunction with adequate training and regular retraining of staff. Other interventions that break the chain with pathogens spreading from the environment onto our patients or babies, using chemicals and materials to clean with microfiber, standardizing environmental cleaning and providing immediate feedback to environmental services workers, control measures for C. diff. Clostridium difficile is one of the top pathogens that we track in the hospital. It is a GI illness that can cause diarrhea, cramping, fever, and it is one of the top 3 pathogens that we track in the hospital setting. Many hospitals are moving towards using cleaners that are very effective against the spore. Clostridium difficile can live on surfaces for up to 6 months. It can essentially live in a spore mode where it almost hibernates for the winter, and it can come out when it reaches a human or a life source like a fluid or a human body. So if it's transmitted from the environment onto patients, it can be pathogenic even after months of living untouched in the environment. Hand hygiene is very effective against Clostridium difficile and every other pathogen in the environment. It's great for prevention of flu during flu season, rhinovirus, any GI illness that you will see very common in the pediatric setting. And there are typically called 5 moments of hand hygiene, and we'll go through these for a few minutes. The first is before touching a patient. So anytime that a healthcare worker enters a patient room, it is expected that they would clean their hands either at the door, the entryway of the room, or right before touching the patient with the in-room hand sanitizer. I like to encourage the new moms to put a bottle of hand sanitizer with them in the hospital or right in their living room in their home so that they can frequently use hand hygiene and it's there and the supplies are available. The second is before clean or aseptic procedure. This may come into play if a mother has a central line, if they have a wound from a C-section, or their C-section is dressed with a dressing. We want to clean our hands before we touch that dressing. The third is after body fluid exposure. So this would be big in the ORs, for instance, if a mom does deliver by C-section. It can also be, let's say, if a mother has a urinary catheter after a long delivery or a C-section, the worker empties the urine, or if a baby spits up or pukes, that this is another time where body fluid exposure, hand hygiene is key. The reason is that many germs like to live in these fluids. They can actually replicate very readily in the presence of the biological material in fluids. So hand hygiene would break the chain of infection if the healthcare worker were to clean up the fluid and then of one patient and go to travel to another patient. That is where germs can spread. The fourth moment of hand hygiene is after touching the patient. So we know that we are colonized with germs. Every one of us has a unique colonization of bacteria on us. And it is important in between patients that healthcare workers clean their hands so that one person's germs does not spread to another, particularly in a setting where there are a lot of immunocompromised patients. And the fifth is after touching the patient's surroundings. So if you think back to that picture with the X's where we showed all of the hospital-acquired surfaces that had VRE on it, we know that if a healthcare worker goes into a patient's room and touches multiple things, let's say they're in the bathroom moving things around, they're on the computer touching items that have been touched a lot, that C. diff that could like to sit colonized that may have not been cleaned appropriately could get onto the healthcare worker's hands and be a source of the next patient's infections if they weren't to clean their hands. So this is a great graphic. We like to put this up in the hospital as a teaching tool and a reminder for the staff of when to clean our hands. There are some pertinent guidelines and standards that do monitor this performance in a hospital setting. When we talked about standard precautions in the use of personal protective equipment to reduce the risk of infection, these are guided by the standard IC 20101, and these precautions apply to all patients. Like you're going to be in contact as a healthcare worker with a potentially dangerous pathogen, blood or body fluid that could present a risk of infection or contamination, you should put on appropriate barriers. This may mean gloves, this may mean the isolation gowns, it could mean a face mask if we're talking influenza, that this is the expectation in the hospital setting to really think about the play. So now we're going to move a little bit into safe handling of the human milk in the hospital environment. So we talked a lot about how the hospital environment can be frequently contaminated and very dirty. It can be a source of potentially dangerous pathogens. So how do we handle our breast milk in this hospital environment so that it doesn't become contaminated in any way? So if a mom needs to use a breast pump and a kit in the hospital, then a pump should be provided for the mother. We will frequently see many hospitals either bring a pump in to the room, or there will be a dedicated pump in each of the hospital rooms. No matter what, the pump that should be brought in should be clean and free of contamination, as well as the kit. Many of the moms will get a new packet of unopened breastfeeding supplies. There's an example on the screen. These are clean prior to opening that kit. So when we do open it for the first time, we should use clean hands prior to touching any equipment before we set up the pumping supplies to our breast pump. And then safe storage is a big key here. So we want to make sure that all of the milk that is pumped in the hospital is safely stored. And there are some great guidelines. This here is from the Academy of Breastfeeding Medicine that shows how long breast milk can sit on a surface, a countertop, in a refrigerator, or in a freezer. Many of our postpartum rooms these days have a refrigerator within the room. We do ask that the breast milk is to be kept into a dedicated refrigerator where the breast milk is labeled with a date, and that food be stored in another refrigerator. So stored milk in refrigerators designated for breast milk only in the main compartments of the fridge. So should we have a dedicated fridge is ideal, and definitely a dedicated space. The temperature should be 39 degrees Fahrenheit. And during Joint Commission visits, this is something that the regulators will look at, particularly is the breast milk being stored at the right temperature. They will take temperature logs of the refrigerators to make sure that it has not had any breaches or drops in temperature that could compromise the milk. And it is recommended that breast milk should not be layered or added to a container that we previously pumped into, so it should have its own container each time. Frozen milk may be thawed on a countertop at room temperature or by placing in warm water. But again, we do not want to thaw the milk in a microwave. And the breast milk should have the date and time that it was pumped, as well as when it was thawed, or that bag should be discarded after use. We covered a little bit about this, how to warm the milk. At home, it is very easy to find a warm basin and to put this in our sink in the home setting. To take some care in the hospital setting as to where we thaw our milk and in what sink. Many of our sinks can be contaminated and are designated for hand hygiene only. And we'll cover that in a second. Research does indicate that human milk has previously unrecognized properties that protect it from bacterial contamination. So even if the breast milk were to come in contact with a dangerous pathogen, it has properties within itself to kill that bacteria. And there is some thought that breast milk does become cleaner over time. So I think there is not a huge need to worry if you feel like your milk has been contaminated by touching it with dirty hands. The milk itself is designed to protect itself and to kill that bacteria, which is just amazing when you think about it. And another comment, the U.S. Centers for Disease Control and OSHA agree that human milk is not among the body fluids that require special handling or storage in a separate container. Many hospitals are moving to milk labs It is designed to preserve the nutritional and immunological benefits of breast milk. It minimizes the contamination and bacterial growth, reduces the risk of patients receiving the wrong breast milk. It increases the utilization of nursing for other patient care needs, improves the consistency and reliability of following procedures, particularly storage and thawing procedures where we can come into trouble with the regulations if it's not done appropriately. And it can ensure that breast milk is sent home appropriately at discharge. So the role of milk labs is huge in the hospital setting, and many hospitals are moving towards putting this in or near their OB units. Safe cleaning of pumping parts is extremely important, and it can be complex. It seems like it may be easy, but within the hospital setting, it is challenging. So we want to encourage moms to clean hands before handling the kit parts and before using and opening the kit. We want to make sure that we have a clean surface or place a clean barrier down before placing the pumping parts on them. Do not just throw them on a dirty chair, for instance. We want to make sure we put a clean barrier or towel down or disinfect the surface prior to placing it there. A great rule of thumb to think of is keep clean to clean and keep dirty to dirty. Keep those separate from each other. So for an extra measure, you could clean the surrounding sink countertop with a disinfectant wipe and allow it to dry. This is a great practice. Clean the parts with warm, soapy water. Remove them, rinse, and allow to dry. We want to use careful measures not to recontaminate the pumping parts while they're drying, which can happen. I like to recommend moms place parts on a clean barrier, lightly cover it with another clean towel, and use clean hands before touching while the parts are drying. An American Journal of Hospital Infection Control study, this is one of many, that found the hospital bath basins are frequently contaminated with multi-drug resistant pathogens. If you go into any mother's new hospital room, you will see that pink basin sitting there, the all-purpose basin. But these basins can easily become dirty and a big source of infection. So we want to be careful that we do not use dirty basins for cleaning pumping parts or for storage of pumping parts because it can be contaminated that way. So again, separate clean and dirty. That's the rule of thumb. And when we look at the guidelines for this, only clean and sterile items should be stored in the clean spaces. Clean items should be stored in clean spaces. Dirty items should be stored in dirty spaces. And no clean supplies stored under sinks. This is a challenge in the hospital setting, dedicated hand hygiene sinks, particularly when it comes to the postpartum rooms where moms are. Clinical hand washing sinks should be dedicated for hand hygiene only. And clinical hand washing sinks are required in all areas where clinical activities are performed. So it is important in the room that there is a hand washing sink for the staff to wash their hands. This becomes a challenge if we want to use a hand washing sink that's dedicated for that action only with an area to clean our pumping parts. And for moms that have had recent C-sections, it can be hard to take your pumping parts down to a designated room where that's a designated sink for cleaning equipment. But this is one of the challenges that hospitals are facing right now, is to balance the need for hand hygiene with a space to clean our pumping parts. If it's used for both, you can easily contaminate your pumping parts due to splashing and dirty hands coming over there. So this is an area where there's a lot of dialogue and challenge both within the infection prevention settings and in the OB departments. With transferring breast milk, you want to use a double pump. And you want to pump into a clean storage bottle, label with the date, and again, store. And if you have a milk lab, that is even more of a benefit to our mothers because this makes this process a lot easier. Let's skip this. So some of the last overview of the guidelines and standards, we want to have standardized processes for cleaning our equipment. So to prevent the spread of dangerous germs from the environment to getting to our pumping parts and also to our moms and babies, we want to have clear processes within the hospital. We want to make sure there's oversight of the cleaning, the disinfection, and the sterilization processes. And appropriately, we need to have logs on our refrigerators and also with our milks, checking our temperatures, and ensuring that our pumps are cleaned, that clinical engineering does PMs or checks of those to make sure they're functioning appropriately, and then we keep our equipment clean with clean hands. So in summary, like Semmelweis noted 150 years ago, there is a strong connection between OB and maternal fetal health and infection prevention. This time is precious. When babies are born, this is just such a unique and wonderful and precious time. So we do need to safeguard it for our moms, our babies, and our families through strong infection prevention practices. I thank you for your time today and for your listening, and I think we will open up for some questions.
Wow. Thank you so much, Kristen. I mean, I know I learned. I'm like on overload right now with so much. So thank you again so much for giving us that very valuable information that can completely help us to prevent and reduce infection in our moms and babies. We do have a couple questions. The first question that a couple people asked is it possible for us to have a copy of the PowerPoint?
Yes, definitely. I will be more than happy to share the copy of the PowerPoint, my email if anyone has questions, and some of the key guidelines as well. So I'd be happy to share that.
Okay, and then maybe we can get your email once we're done, and then we can send it out, and then individuals who would like a copy can just request it personally. That'd be good. The other question is, what soap is appropriate to clean the pump part? And then also, size containers for each individual patient use only?
Okay, so that was a couple parts. So let's take the first part. Did I hear it correctly? What soap is appropriate to clean our pumping parts?
Yes.
Okay. I do recommend some of I don't want to list product names or companies, so if someone has a specific question, I can email you personally after this. But many of the breastfeeding companies do have some very nice soaps that have great emollients in it. The role of a soap, a very good detergent, is to dislodge particles and biological burden from the pumping parts. So I always say it's very important after you pump to immediately soak or rinse the bottle, the flange, take apart everything, including the white membrane, and every single part of it, and soak it if you can't get to cleaning it immediately, because we know baby comes first, or rinse it, because the proteins will sit there, the milk will dry, and that can create a biofilm. So you want to make sure you dislodge that and rinse it out. And then some of the soaps that these breastfeeding companies provide are really great. They're soft, they're meant for the pumping parts, do a great job of lathering up and getting off the bioburden. I know that many moms in the hospital setting will use the hand soap within the room, and that's okay. Those hand soaps are typically highly antibacterial and can be very caustic and have emollients in it. it's not necessarily designed for equipment cleaning, but if that's all that you have, it will work too. You just want to make sure you adequately rinse it very well, since those are antibacterial soaps. What was the second part of the question?
Yes, I'm sorry. The second part was you mentioned there should be individual size containers. Should those individual size containers, when it comes to cleaning, be for, like one patient only?
I may have to answer this offline because I'm not sure what they mean by containers, if they mean basins or the pumping bottles. I think we did touch upon that each milk pump should be stored in a separate container. I do really recommend, though, the breast milk storage bags. The reason for that is that you can flatten out the milk and it will freeze uniformly in that bag. It will stack one on top of the other. And from a temperature control standpoint, that's ideal. You want your milk to freeze very quickly. You want it to freeze at the same time, both the bottom, the middle, and the top. So I think those plastic bags are great. You can also label with a Sharpie right on them and write when you pump the milk. And they're easy to thaw. They thaw pretty quickly in the plastic bags. So that's usually where we recommend storing the milk for single use.
Okay, and I got a little bit of clarification on the question. She's referring to the soap container. The individually sized.
Oh, soap container. I'm wondering if this is the basin that we referred to. So I will assume that it's that. That pink the pink hospital basin can be the bane of our existence, but it's also one of the biggest necessities for moms. And I know that when I was given that in the hospital, that was the go-to spot where I soaked my pumping parts. I got a nice soapy warm water, I soaked it in there, and I cleaned out the debris. And if I didn't have time to clean my parts because I was caring for my baby, which was obviously the top priority, I would allow the parts to soak in that water until I could get to the part of cleaning them. If possible, I recommend getting 2 basins, one to dedicate for the washing and the other dedicated to the clean storage of the pumping equipment. This way, it has the sides, it's a clean container, you can label it as clean, and it's less likely to be contaminated. So this would be an ideal setup if that's possible.
Okay, cool. And as time winds down, I do have one more question here. The question is, if there is a sink within the patient room, maybe the clinical designated one, and there's also another in the patient's own bathroom, where would you recommend she clean her pump part?
So I knew that this question was going to come up, and I think that I can answer this offline with more specifics, but what I would do as an infection preventionist is I would first walk that space, and I would want to determine, is there a milk lab with dedicated sinks in use by there, because that would be a top choice. If there is not any other sink like a milk lab available, we'd want to probably do a risk assessment to see where would be the optimal sink. As a mom that had C-sections, I know that it's hard to get up and walk very far, so that in-room sink can be very important. If it is used for hand washing and cleaning, this can be a regulatory issue. It's something the hospital's administration is going to have to take into consideration and get with your facilities people to figure out what would be the best future plan for that. But if we're dealing in the here and now, and this is all that we have available, we may either have to designate that bathroom sink as a hand washing sink and that in-room sink as a pumping parts cleaning area. No matter what, go back to the principle I stated earlier, keep clean to clean and dry to dry. So even if we can designate part of that sink or a certain shelf as our clean space, we want to do that and label it appropriately. This is just going to help with contamination. I wish I had a simple answer for this. This is one of the most challenging topics right now that we have to deal with in this setting, but it's really going to take looking at your organization, working with your administrators, your facilities, and walking, you know, the postpartum unit with your infection preventionists and your unit leadership to determine the best course of action. Patient consultants involved too.
Okay, thank you. And then, I'm sorry, one more question, just because I think this would benefit most of us on the call. Is it acceptable for moms to place bottles and flanges into a Ziploc bag and place it in the refrigerator between pumpings at work? Because this is especially important because time is usually a factor for pumping moms.
Yeah, this is a great question. I could do a whole PowerPoint on pumping moms and the challenges. As someone that's pumped in dirty airport bathrooms and in stalls where there was no dedicated pumping area, hygiene, you do the best that you can do with what you have at the moment. And what I have done in the past, I do like, there's a couple quick clean wipes out on the market. Even if you could wipe down the inside very quickly, rinse it, and then put it in the bag so that it's dedicated as dirty equipment, and then bring it home and give it a more thorough clean later. That works perfectly. As moms, we're used to just thinking on the fly and coming up with the best that we can do at that point. So I think that's a great option. I'm a strong believer in those wipes because you can wipe them down. It takes like 30 seconds and then dump them in a bag and clean them better when you get home. Great question.
Okay. Thank you so much, Kristen. I would love to sit on the phone with you for hours. I got lots of information, and I think all of our audience did too. So thank you again so much. Before we get off of the call or the webinar, I would like to remind everyone to please join us on August the 26th for our annual State Breastfeeding Conference. We have the wonderful Kimberly Sears-Allers. She's going to be our big keynote speaker this year, and she's going to be talking about her new book, The Big Letdown. So I am very excited about that. We would not want to leave this call without thanking our sponsor, St. Vincent, and then we also want to just make a note that Indiana State WIC and Indianapolis Healthy Start are bringing Ms. Kimberly Sears-Allers to our annual State Breastfeeding Conference. Thank you guys again so much for taking us out today, and we look forward to talking to you guys again on next month. Have a good afternoon.